Good afternoon to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Aviyudhya Verma. Sir is MBBS, MD Medicine, DNB, FACE, Associate Professor at the Department of Endocrinology at Index Medical College, Indore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is obesity and endocrine function. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Ms. Rion, and thank you, Team IJCP, for giving me this opportunity to interact on this very important. Although, friends, this topic looks very simple and straightforward. That what is such a big thing about obesity? It is just uh, extra adipose tissue, and we know there are mechanical problems, skeletal problems due to obesity, and it increases blood pressure and blood sugar levels. But I would say in the last 1 decade or so, the perception of obesity has changed a lot, because in my coming slides I would be talking that how endocrine dysfunction leads to increase in weight, and how the increased weight leads to dysfunction of various endocrine organs. So this is like a vice versa. If you want good to be in one thing, we have to take care of the other thing. So without wasting much time, we'll see that how this all happens. So this is a very simple diagram, but here you can see this. This is the hypothalamus. Especially I would talk about here the ventromedial hypothalamus, which takes care of satiety. So stimulation of this part brings about a early satiety. And on the other hand, the stimulation of lateral hypothalamus, it stimulates the hunger, or it causes hunger signal. So it is basically the balance of these two things. And this balance is maintained by various neurotransmitters and various hormones which regulate this hunger and satiety. And damage by some syndromes or genetic causes or even a mechanical cause can disturb the balance between the hunger and satiety, leading to weight problems in an individual. So this we should know, because this will be our main, you can see, the way how we would be proceeding in future, even when we talk about the treatment aspects also, which I shall not be discussing this time, but definitely we should know about these hypothalamic nuclei. So what is appetite? Again, as I told you, it is basically the balance between the hunger and satiety from the hypothalamus signals. So appetite is a complex process that results from the integration of multiple signals at the hypothalamus. The hypothalamus receives neural signals from leptin, cholecystokinin, ghrelin, and nutrients signal like glucose, free fatty acids, amino acids, and volatile fatty acids. So these are some of the direct or indirect regulators of appetite, which sends signal to the hypothalamus, and then the hypothalamus gives the signal accordingly. And this is in short, I won't go in detail. We have hormonal circuits from the gut, especially the stomach, the small intestine, and pancreas. And obviously, as I said, the topic of today, the adipose tissue or fat, which impact the sensations of hunger and satiety exerted via hypothalamic neuroendocrine pathways. That's why my first slide was basically to understand the hypothalamus. Ghrelin, which is secreted from stomach. The leptin, which is again secreted from adipose tissue or fat. The insulin from pancreas and peptide tyrosine YY from the small intestine. They bind to their receptors on orexogenic or anorexogenic neurons in the ARC of the hypothalamus. The effect of these various peptide hormone receptor interactions are the release of either the orexogenic neuropeptide NPY and AGRP, which we'll see in the coming slide, or the anorexigenic neuropeptides CART and the POMC derived peptide alpha melanocyte stimulating hormones. So these are basically the hormone receptor interactions which increase or decrease the appetite in a person. And here, this is a very beautiful diagram. You can see here, looks quite busy, but you can see down, we have insulin from pancreas, PYY from small intestine, then we have leptin and insulin from, leptin from adipose tissue and ghrelin from stomach. And what they have, in fact, you can see here, they have effect on AGRP and NPY, which are orexogenic neurons. And then we have anorexogenic neurons like POMC and CART, which are basically taken care by the insulin receptors and leptin. So ultimately, these are the first order neurons. Then they are in the periventricular nucleus, the second order neurons, where we have this MC4R receptors and Y1 receptors, which take care of the satiety center. So if the satiety center is stimulated, the person feels satisfied and stops eating. So if it is not stimulated through this pathway, then the person feels hungry. So this is all you can see, the interplay from the small intestine, pancreas, and adipose tissue, and ghrelin from stomach, which ultimately has effect on hypothalamic nuclei and control of satiety and hunger. So this was again same briefly. And when we talk about adipocytes today, here you can see what happens here. This is a fat cell. And here what happens, excess energy is stored as fat in these adipocytes, which expand until the fat is used for fuel. So this is important. You can see this swells up, storing the energy. And we know also we have two different type of fats, a good or brown fat, which is quite metabolically active. In fact, it helps our body to increase the metabolism and control the body fat. But white fat, on the other hand, has got a lot of fat inside it, and it is considered to be bad. And as the age progresses, we tend to get lesser and lesser brown fat in our body and more of white fat, which is bad for our health. Now, I won't go in detail, but these are some of the other, you can see, endocrine causes of obesity. And ultimately, they are all somehow working on leptin, on ghrelin, on insulin secretion, and other neurohormonal causes. So here we have Cushing syndrome, where we have excess of cortisol, which increases the fat. Hypothyroidism, which reduces the metabolism, the basal metabolic rate through its again influence on melanocortin receptors, ultimately leading to increased weight, or you may say increased fat deposition. Then we have hypopituitarism, where a lot of hormone deficiency occur due to various reasons, leading to deranged hormone balance and increasing the weight or obesity. Then we have some syndromes due to genetic causes like Prader-Willi syndrome and Lawrence-Moon's syndrome, where we have seen morbid obesity even in children. This I won't go in detail, but just to understand that how modest weight gain or loss in a non-obese person mainly affects the size but not the number of adipocytes. But when these adipocytes reach their maximum size, further weight gain is achieved by recruitment and proliferation of new pre-adipocytes. And when there is weight reduction is difficult after the cell has already proliferated, because the fat cell must become smaller than their normal size if we want to see a weight reduction. So this is why the people who gain weight and then the excess fat is stored in these pre-adipocytes, there is weight gain, and until unless the size of these adipocytes becomes smaller, the patient gets problem in reducing weight. So this is a very complex phenomena, and it's not as simple as it looks. But and what these adipocytes or adipose tissue, which is now one of the biggest endocrine organs in the body, producing various hormones. You can see here a lot of things are produced by the adipose tissue. The bone morphogenic protein, IGF-1, BP3, pro-inflammatory cytokines, TNF alpha, TGF beta. Then we have interleukins, we have fatty acids, prostaglandins, we have plasminogen activator inhibitor, angiotensin 2, estrogen, adiponectin, resistin, leptin. So these are hormones and other pro-inflammatory markers produced by adipose tissue. So you can see this adipose tissue produces so many hormones in the body, and we'll see one by one these hormones, the adiponectin, the leptin, and the TNF alpha and interleukin. So as I was talking about leptin, the leptin has a major role in body weight regulation by sending signals of satiety to the hypothalamus. And we have seen in my previous diagram that how the leptin does it. Thus, it reduces the dietary intake and fat storage while modulating energy expenditure and carbohydrate metabolism to prevent further weight gain. So here you can see that how adipose tissue sends signals to hypothalamus, and then we have apparent signals that maintain food intake and energy expenditure. And then starvation, this becomes opposite. Then we have neuropeptide Y, which stimulates feeding. So this is, it increases the hunger, again acting through hypothalamus. This is a model how the leptin regulates the neuropeptide Y. So this is again that when there is a secretion of leptin, it decreases the neuropeptide Y hormone, and in turn it reduces the food intake. So you can see how this interplay between the leptin and neuropeptide happens here. So when food intake is more adipocytes are there. With adipocytes, the signal leptin hormone is produced, and this excess leptin then decreases the level of neuropeptide Y to reduce the food intake to keep the body's weight under control. And this again, same diagram you can see here, the leptin, and then it takes care of these anorexic neurons, POMC and CART, and then in paraventricular nucleus, it takes care through melanocortin receptors, takes care of satiety. Again, I won't go in detail. A lot of things are to be discussed here, but here, this is again same representation, how it happens, food intake and food. Increased leptin levels cause activation of POMC and CART neurons, as I've already told you. It increases the alpha melanocyte stimulating hormone in the second neurons in the paraventricular nucleus, and then it activates the melanocortin receptor 4, which reduces the food intake. So this is the whole scenario. How the mechanism of leptin and other hormones play in causing hunger and satiety. But then there are few studies which show that there is a paradox of leptin and obesity, something known as leptin resistance. So here I've told you that how low leptin levels stimulate hypothalamus and increases the food intake and causes low energy expenditure. But studies have shown that even when there is a very high leptin levels, then the person may have leptin resistance also through melanocortin 4 receptors. And this is what happens in obesity, that the person goes for unlimited food intake and low energy expenditure, leading to increased or severe obesity. So sometimes good leptin increases to control the weight also, but then there is a leptin resistance which becomes or makes the person more hungry. Because of the resistance, it cannot take care of the satiety center. Then we have another adiponectin produced by the adipocytes. This is a type of cytokine having anti-inflammatory property and cardioprotective effects. And it improves the insulin sensitivity also. So adipose tissue is good because it produces leptin, it produces adiponectin also, which has got anti-inflammatory property and cardioprotective also. It gives protection from insulin resistance, type 2 diabetes mellitus, and coronary artery disease. So these are good hormones produced by adipocytes. Then we have resistance, which has got bad effects because it increases the levels of LDL. Women, we know they have polycystic ovary syndrome. They have these resistance, which may increase the weight in these PCOS females. In males, we may have reduced plasma testosterone levels and SHBG level, and increased estrogen levels and cause gynecomastia. So these are some effects of resistance in both males and females. Yes, leptin, other than taking care of satiety, takes care of the puberty. Now, sometimes it is proper leptin produced by adipocytes is required for a normal pubertal development, because leptin binds to ARC kisspeptin. It increases the kisspeptin levels, and it is said to be a gatekeeper of mammalian puberty. So here you can see that how a good leptin level can induce the kisspeptin level and ultimately start the GnRH pulse generation and increase in the LHFS level for a normal puberty. So this is all you can see here. Yes, adipocytes are good, especially the leptin, because it can affect the GnRH generation for a normal puberty. Then we have this again, the metabolic control of puberty through leptin and kisspeptins. I won't go in detail. These are the neuron. Leptin, produced again by adipocytes, has a role in bone homeostasis also. And this leptin, it improves the bone formation and reduces the bone resorption. Again, the details I won't go, but here you can see again leptin goes to hypothalamus, and from hypothalamus it acts on the osteoblast and reduces the osteoclastic activity. Here you can see, and immune cells also. Leptin enhances the phagocytic activity of macrophages. It promotes pro-inflammatory cytokines also. It stimulates chemotaxis in polymorphonuclear cells also, and it promotes lymphocyte survival also. Then we have the effect of leptin on vasculature. Here you can see the effect on ether. It improves the nitric oxide production and ultimately helps in proper vascular relaxation. When we talk about these abdominal fat cells, they are quite larger. That's why a lot of people who have insulin resistance, it is due to basically the abdominal fat cells, which is more harmful. They have higher rate of fat turnover. They are hormonally more responsive. So whenever there is a hormone imbalance, especially males or even in females, like in PCOS, they tend to get abdominal obesity. And these substances released, especially from abdominal fat, are absorbed via portal vein, and thus they have a direct access to the liver. And these fatty acids are taken up by liver, leading to insulin resistance and increased synthesis of triacylglycerols, which are released as VLDL. So abdominal fat is more dangerous compared to the subcutaneous fat. And here, again, I won't go in detail, but you can see here, adipocytes, when they go for hypertrophy and hyperplasia, leads to various cell dysfunctions, beta cell, oxidative stress, insulin resistance, hepatocytes leading to lipogenesis, insulin resistance, steatohepatitis, increase in adipokines, free fatty acids, and inflammatory markers throughout the body, causing damage. And here we'll see a little bit about the obesity and metabolic syndrome. So, and sleep deprivation. Sleep is also very important to reduce weight. If there is sleep deprivation, it may lead to metabolic syndrome and obesity. How? It does because increase in the nighttime GH and cortisol level, increase in the sympathetic activity, fatigue, altered thermoregulation, leading to energy reduced energy expenditure, insulin resistance, then increased oxygen, reduced leptin and increased ghrelin. So there is increased appetite and food intake, leading to obesity. So you can see just with the sleep deprivation, the whole metabolism and the hormonal balance is disturbed, leading to metabolic syndrome and obesity. Again, they all lead to cardiorenal metabolic syndrome, hyperuricemia, increased aldosterone levels, leading to hypertension, microalbuminuria, endothelial dysfunction, and all. So this is the whole scenario. You can see that how some fat cells in a good proportion can help our body to stay fit, but some hormones may lead to malfunction of various organs in the body. Obesity is also a very well-known factor to cause various types of cancers. I won't go in detail, but these are all due to increase in the pro-inflammatory markers. They reduce increase oxidative stress, and also you can see here from head to toe we can get a lot of cancers just because of obesity. And this is, I won't go in detail. Again, the same thing, the resistance, adiponectin reduction is there, resistance increase, insulin resistance. Then we have insulin-like growth factors, BP1 and 2 reduction, increasing IGF bioavailability, where there is reduced apoptosis and increased cell proliferation, leading to tumor development. So ultimately, what is adipose tissue? It is not only fat, it takes care or it takes important role in puberty, immunity, metabolism, and bone metabolism also. So adipose tissue is important. We have seen a lot of hormones are produced by adipose tissue, which are good and some are bad. So a proper weight maintenance in normal body is required to have good reproductive system, good bone homeostasis, good immune system. Central effect is the energy homeostasis. So adipose tissue takes care in all these hormonal and metabolic mechanisms. Thank you. So can we have some more?
Yes, sir. So we do have some question from our audience if you like to take that up.
Yes, please, please.
Sure, sir. So, sir, the first question is, what are the key clinical indicators that should prompt further investigation into endocrine dysfunction in obese patient?
So I think first of all, as we know, overweight is okay, manageable. We may not get a lot of problems due to overweight, but whenever an individual enters or the BMI is more than 27 in Indians, or if we take globally more than 30 kg per meter square, then this should be a factor which should alert us that yes, this is the adiposity which is going to disturb various metabolism and hormonal balance in a person's body, especially if the obesity is abdominal obesity, means the fat is accumulated especially around the waist, which is known as android obesity. Gynecoid obesity is somewhat okay, like the fat deposition in hips and thighs.
Thank you, sir. The next question is: what are the long term metabolic consequences of obesity on endocrine organ, and how can these complications be mitigated or managed?
Correct. I think I have shown nicely in my talk today that how the obesity can affect, as I have shown in males we may have problem with the testosterone level, in females we may have problems with the menses, the polycystic ovary syndrome. Then we can have problems in severe obesity related to the hunger suppression because there is leptin resistance. Then we have increased pro-inflammatory markers, which can lead to various other uh, metabolic abnormalities in body like dyslipidemia, hypertension, insulin resistance, leading to type 2 diabetes mellitus. We have then the skeletal problems also because of weight bearing. So it is basically like, and as I talked in and about, certain types of cancers are also seen more in the obese individuals. So it is a whole plethora you can see. Not a single organ in body is spared. I've talked about liver also, which gets affected due to obesity. And it's various, you can say, the adipocyte related, the adipocytokines, pro-inflammatory markers. And the only way, the easiest way, and the best way, I would say, that from the beginning, whenever a person becomes overweight, we should start counseling them to reduce the weight through proper lifestyle measures, especially the diet and exercise. They play a very important role. Medicines, I have not talked specially because they are to be discussed separately, but medicines only help when the person has a good lifestyle. Otherwise, medicine effects are very short term, and they only help us to reach a certain target of weight, and then the person himself or herself has to continue on lifestyle intervention only.
Thank you, sir. There is one last question, which is: how often are clinical guidelines for the management of obesity related endocrine disorder updated, and what recent changes or recommendations should clinician be aware of?
Correct. Of late, in past couple of years, the obesity has taken a very important role. Whether we talk about a gynec problem, whether we talk about pediatric problems, whether we talk about the male or female sexual dysfunction, and including increase in the non-communicable diseases like diabetes, hypertension, heart disease. Everywhere we see the guidelines have now started talking about the weight reduction. And we now have in guidelines, especially I can give you example of treatment of type 2 diabetes mellitus, where they have put specifically weight reduction medicines which help in reducing the cardiac and renal and metabolic abnormalities should be given preference. It's not only good sugar control or good blood pressure control, but the guidelines now they insist more usage of these drugs who help to improve the vascular dysfunction and to reduce the obesity also. So these are the latest guidelines. They have done a lot, and they have specially guided us that weight reduction is very important in all these disorders.
Thank you so much, sir, for answering all our questions. So that's all from our audience side. And before concluding today's session, sir, any last remark from you?
Thank you. team IJCP, and thank you all, my dear friends. I just want to say one thing through this talk, that obesity is a very complex phenomenon. We have seen there are a lot of hormonal, neuroendocrine, and various uh, brain nuclei involved in this. But whatever may be the case, our first aim should be to counsel patients for a healthy lifestyle, and then whatever the pharmacotherapy is there, we should advise them. Thank you.
Thank you so much, sir, for joining us today. With your permission, sir, I would like to